Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful Cape Town. It's wonderful to have so many hundreds of people logged on, and it's my great pleasure and privilege to welcome our co-host, which is Professor Steve Jeffrey. The Pelvic Floor Foundation of South Africa will be sponsoring this presentation this evening, and backed by popular demand is Dr. Jocelyn Hellig, and she is an endocrinologist and will be speaking about weight loss, everything you wanted to know but were too afraid to ask. And as we were speaking recently just now, the number of women and men, but especially women obviously, that are asking for different types of interventions to improve their weight loss, whether or not it's justified, is enormous. So it gives us great pleasure to invite Dr. Jocelyn Hellig to share her slides, and we look forward to with great interest to weight loss, everything you wanted to know but were too afraid to ask. Steve is going to be thanking her. Just to remind you, ladies and gentlemen, that next week we have Ermos Nicolau, and he's going to be speaking about first trimester screening. And the final thing I'd like to mention is, as you know, FIGO Congress in Cape Town is going to be on the 5th of October at the CTICC, and anybody that still wishes to register, we have a few places remaining. So with no further ado, Dr. Jocelyn Hellig, weight loss, everything you wish to know but were too afraid to ask. Jocelyn.
Thanks very much for the introduction, Peter, and it's a really great platform to be presenting at. I think I'm actually a closeted gynecologist, so it always brings me great joy to speak to a room full, or a home full rather, of colleagues. So thanks very much for having me.
Now you can come out of the closet, Jocelyn. I've always thought you were in the closet.
Thank you. I'm not sure how good my surgical skills still are, but I can definitely sort of still write out prescriptions. So this is a topic that, when I speak to colleagues and I speak to patients, often elicits a variety of different emotions. Weight loss is not a neutral subject in 2025. And this is because for a lot of us, it is a very personal topic. So when I pose this question to a room full of people, I ask, everyone to please put up their hand if they've ever tried to lose weight. And I would imagine a lot of you sitting at home or sitting in your offices this evening have probably tried to lose weight at some point in your life with varying degrees of success. You'll be glad to know that we are not alone. And if you Google, how can I lose weight, 356 million pages come up. So really, the weight loss industry, the diet industry, and now the pharmaceutical industry is a multi-billion-dollar empire. And unfortunately, even though this has led to significant advances in how we can manage patients with obesity, it does expose our patients to who are a very vulnerable population to a lot of mismanaged and pseudoscience, which I'd really like to caution you against. So being a female doctor in 2025 and being a female doctor who predominantly manages female patients comes with a specific set of challenges, and I'm sure a lot of you listening this evening will experience the same thing. So I'm finding it increasingly difficult to manage what patients read on social media, whether that's Instagram, Threads, or TikTok. And almost universally, patients will bring what they've researched on these social media platforms into the consultation. And it's made the landscape of managing women really challenging because, unfortunately, women, whether they're teenagers in their midlife, are a very vulnerable group of individuals where we're always looking to improve something about ourselves. And unfortunately, a lot of influencers, Hollywood celebrities, and even some medical doctors on social media have taken significant advantage of this. So I think I'm not the only one here this evening who thinks Gwyneth Paltrow was better off acting in movies instead of trying to sell us vagina-scented candles and telling us that mammograms cause breast cancer. These are just some of the other popular personalities on social media who I really need to caution you about treating with a grain of salt and a healthy dose of skepticism. So the glucose goddess, who advises all of us to wear continuous glucose monitors with absolutely no evidence, the so-called menopause guru, Mary Claire Haver, and then Stacey Sims, who is a fitness, an exercise physiologist, who really, unfortunately, propagates a lot of myths about women's health and about women's wellness, particularly in terms of fasting, exercise, and exercising according to your menstrual cycle, which we all know really does not have a good evidence base at all. So before we dive into tonight's topic, I really want to set the scene in your office. And because we know that obesity is very closely tied to weight bias and weight stigma, it's really important that we are very intentional in how we speak to patients and how we approach management in discussing weight. And this applies more to obesity than with any other chronic disease, because most other chronic diseases do not come with inbuilt bias and stigma. So it's important that we approach these discussions in a non-judgmental way, and there should not be weight bias and weight stigma in our consultations. And it's important that we are aware of our own internalized weight bias. So weight bias means that you think that someone who has obesity because they're lazy, they have no self-discipline, and their weight is entirely within their control. And then weight stigma is actually acting on those beliefs. So it's saying to someone, I'm not going to give you medication because you've done this to yourself, and I think you should be able to get yourself out of it. So those are two really important concepts that I want you to take home with you. Your office needs to be welcoming to patients who live in bigger bodies. So your chairs need to be of a certain size that can accommodate bigger patients. Gowns need to be able to close properly, and equipment needs to fit patients who have obesity. It's really important, and I know that gynecologists are really good at doing this in general, to listen to what your patient's concerns are, discuss their goals, and discuss your goals as well. Because what you want for that patient and what the patient wants for themselves are often not the same thing. So when we discuss management and we discuss shared decision-making, setting common goals is a really important part of that. I always tell my patients, as an endocrinologist, I want you to be metabolically healthy and I want you to be mechanically well. So I want you to be able to do the things that you want to do without your weight being a significant impediment. But patients might have different goals. They might, for example, want to fit into a certain pair of jeans. They might want to get onto an airplane and not ask for a seatbelt extender. They might want to shop at average size clothing stores. And although some of these may be seen as vanity or superficial goals, they're not. There are quality of life concerns that we need to take seriously.
Josh, something that I've brought up has come up quite a number of times in my career is where surgeons will often say to patients, well, I want you to go and lose 10 kgs, 15 kgs before we do an operation. And, I've always found that a little bit difficult because, how do you justify that firstly, and how do you get the patients to actually do that? If the surgery is indicated, it's indicated or not. But what are your thoughts on that? I mean, Pete, have you experienced that as well, where patients have actually, been told by doctors to go and lose weight before they do their op? And what are the thoughts?
Very commonly, Stephen, yeah. Look, in all honesty, I can see why it is, because if you have a woman that weighs 150 kilograms, it's extremely dangerous. We're not talking fat shaming or bodily habitus shaming. We're just talking practicalities in terms of not only the surgery, but also post-op DVTs and so forth, Clexane or what have you. you actually have a higher profile risk if you are a woman with a higher BMI. Jocelyn?
Yeah, absolutely. So, I don't think we can argue that significantly increased BMI poses certain additional risk factors intraoperatively and postoperatively. And it is also beyond argument that weight loss will probably improve the surgical outcome and the post-operative outcome for a lot of procedures. I think the question here is more how we have the discussion with someone and what we can offer them in terms of treatment. So it is one thing to say to a patient, you really need to lose weight before this operation, otherwise it's going to be a disaster, versus weight loss for you is going to improve your outcome post-operatively and make the operation a lot safer, and this is how we are going to do it. So, I definitely think that it is a conversation that needs to be had when patients are going for certain procedures, but there is a way of having the conversation. And the important thing is giving the patients the tools to achieve the weight loss that the surgeon requires. So our number 4 point here is not blaming every symptom that the patient has on their weight. For example, change in bowel habit may not be due to their weight. Their itchy eyebrow may not be due to their weight. Their sore toe may not be due to their weight. So it's very common for patients to have their symptoms dismissed using having obesity as an excuse to explain the symptoms. But that is bad medicine, and it leaves patients vulnerable to a lot of misdiagnosis. And then finally, and this is a really important point for me because I see a lot of mismanagement of obesity, is that you need to familiarize yourself with the facts, the science, and the evidence on the modern management of weight. And this is what we're going to speak about in the talk. So the obesity world is currently in a state of flux because there is a lot of discussion and a lot of contention about what actually composes or constitutes rather the diagnosis of obesity. So we used to use BMI or body mass index as the only way to diagnose obesity. And this is a calculation that a lot of you are probably very familiar with, and it's something that's very easy to do in our rooms. So you take the the weight in kilograms over the height in meters squared, and you get a number. So the so-called normal BMI is between 18.5 and 24.9, while obesity is classified as having a BMI of 30 or more, and that is then reclassified in 3 classes. The cutoffs are slightly different in patients of Asian and South Asian descent, where we know that those individuals develop the complications of excess adiposity at lower BMIs. So BMI has come under a lot of criticism, especially by people on social media. And this was a tweet that went viral a couple of years ago before Elon Musk took over Twitter, where this obesity physician in the USA said BMI is trash. Now, I do not completely agree with what she's saying, but I do think there's a little bit of merit in her comments. So BMI just tells us how big someone is. It does not tell you anything about how much fat someone has, where that fat is actually sitting, and what that fat is actually doing. So it should rather be seen as a screening tool to have a conversation about weight and a screening tool to pursue complications of excess adiposity even further. So BMI is not completely trash because we know that there's a very good correlation between an increase in BMI and a reduction in life expectancy. So you can see here, when your BMI increases to between 35 and 40, you have a 60% chance of reaching the age of 70 compared to a normal BMI, where we know that you have an 80% chance of reaching age 70. When your BMI increases to above 40, and that was what we used to term class 3 obesity, you have a 50% chance of reaching the age of 70. So it is not trash, but it should not be seen as the only criterion for health. So things like waist measurement, waist to hip ratio, waist to height ratio, and in-body composition scales are far more useful tools in telling you how much fat this person has and where that fat is sitting. So we know that a waist circumference of more than 80 centimeters in women is considered to be abnormal, no matter what their age. So this actually tells us where that fat is sitting. It's visceral fat, and we know that it is strongly correlated with an increased risk of cardiometabolic disease. An in-body assessment scale is a really helpful tool, but not many practices will have this. So that is a scale that tells you how much fat you have, how much muscle you have, which is lean muscle mass, and how much water you have. And that's really helpful when you're in a weight management space and following patients up who are on weight management plans. And then finally, the gold standard to assess excess body fat is really a DEXA assessment. But a waist circumference and a waist to height ratio are really helpful, practical things you can do in your rooms. So what then evolved was in 2020, the Canadian working group, or the Canadian Obesity Clinical Research Group, released an incredibly helpful and practical guideline that we call the Canadian Adult Obesity Clinical Practice Guideline. And this is actually the guideline that we're currently adapting to a South African setting, and it should be released in the next couple of months. So they explained obesity as a complex disease being the important part there, in which abnormal or excess body fat impairs health. So you can see here, it is all about fat, okay, and what that fat is doing. So we know that the effect of excess fat can have a detrimental effect on physical health, quality of life, and may reduce lifespan. They also went on to say BMI is not an accurate tool for identifying obesity-related complications, because that really just tells us how big someone is, and it doesn't really tell us anything more. They also elucidated that it is prevalent, so it's common, it's complex, it's progressive, and it's a relapsing chronic disease. And this is a really important phrase here, because what happens in patients with obesity is that they go into remission, so you lose weight, and then you relapse, where weight regain happens. And that is the universal path for almost all patients with the disease. So BMI tells us how big someone is, and that's what I want you to remember. But it doesn't tell us anything about where the fat is sitting and what the fat is doing. So in an attempt to try and refine this diagnosis, this Lancet Commission published a working definition in January 2025. Now, whilst I appreciate an attempt to refine the diagnosis, a lot of this is quite complicated for people who are not necessarily managing this disease on a daily basis. But what they attempted to do was to differentiate between preclinical obesity and clinical obesity. So what they've said with preclinical obesity is that you can have excess adiposity with preserved health. And that was the so-called healthy obese individual that we used to refer to. So this means that you have completely normal organ function, but you have excess adiposity. That is differentiated from clinical obesity, which is when it becomes a chronic disease. And this is when you have organ dysfunction, you have metabolic issues, mechanical issues, or musculoskeletal issues, and it defines an ongoing illness rather than grading risk. So they differentiate between having excess fat, but it's not doing anything bad, versus having excess fat and it's doing something bad. I'm not going to go into this in too much detail, but essentially this is quite a nice way of pointing out the problem by just looking at BMI. So what they attempt to compare here is that if you have someone who is in a so-called overweight range, so that's having a BMI of 28.2, for example. Does this patient have excess body fat? Yes. Do they have signs and symptoms? No. But this might lead to the underdiagnosis of obesity because this person has excess body fat, which is actually causing potentially a complication with their physical health. So we might not identify patients with excess body fat, which is doing bad things at lower BMIs. Conversely, this is an unusual situation, but if you're a sports medicine doctor, you might see it more frequently. We have patients with high BMIs of over 30 who are athletes, and this is because they have a high muscle mass. So we might be overdiagnosing obesity in that population. For example, a lot of the Springbok rugby team will have a BMI over 30, but they do not have the disease of obesity. So I hope this is beginning to illustrate a little bit of the practical issue with BMI. But what I see in my practice is mostly this group, where patients with BMIs in a so-called overweight range or even in a high normal range may be missed in terms of having excess adiposity, which is causing a problem with their metabolic health. Okay. So how prevalent is the problem in South Africa? So this was taken from a large population study a couple of years ago. And what you can see from the graph is that almost 70% of women will fall into an overweight or obese category according to BMI, and just below 40% of men will fall into a similar category. So it is a prevalent disease. So just to dispel some myths while we're at it, in the name of combating pseudoscience. So myth one is that obesity is not a disease and weight is entirely within your own control. Let's try and break that down. So before I started doing a lot of obesity medicine, I did not realize how complicated eating and appetite were. Excuse me. So we actually have two kinds of eating. We have eating for hunger, which is known as homeostatic eating, and that's located in the hypothalamus. We then have hedonic eating, which is eating for pleasure, and that's controlled in our limbic system, which is in the brain's reward system. We then have executive function, which is deciding to eat, and this is located in the frontal lobe. These two types of eating are located in the subcortical parts of your brain. So that means that you have no voluntary control over homeostatic or hedonic eating. This implies that this is a subconscious feeling. So you cannot decide to be hungry. It is just something that happens to you, like if you need to go to the toilet to pass urine or if you need to yawn. So hunger is entirely beyond that patient's voluntary control. Where we do decide to eat is with executive functioning. So that is under voluntary control because it's located in the frontal lobe. But as all of you know, it is very difficult to resist hunger indefinitely. And that is why diets that rely on self-discipline long-term are universally ineffective for most people. So I'd like to thank my colleague Wayne May for this slide, and it really is helpful in differentiating the causes of obesity versus the contributors. So causes of obesity are things that the patient cannot change, whereas contributors are things that the patient may be able to change. So causes are associated with an impaired energy balance over time. And these are due to things like an abnormality of appetite, so increased appetite and or a reduction in satiety, altered digestion, increased fat storage, and a reduced metabolic rate. So the contribution of these various factors may vary in different individuals, but we know that the appetite abnormality predominates in most people. Now, contributors are things like dietary choices, exercise, psychological health, and medication. And the contribution of these various abnormalities varies within each patient. It's important to understand that these are not causes. So if someone says to you, I'm an emotional eater, the emotion is a contributor, it is not a cause. So just addressing the causes, for example, emotional eating, is not necessarily going to address the underlying, just addressing the contributor is not necessarily going to address the underlying cause, which for most people is appetite. So the two need to be done simultaneously. So our second myth is that it's all in your genes. So the genetic contribution to BMI is in the region of about 40 to 70%. So it is pretty high. And this is a polygenetic inheritance pattern. So doing gene testing for patients is universally unhelpful for most people. If you are born to one parent who has obesity, your risk of developing the disease is 3 to 4 times increased. If you are born to two parents who have obesity, your risk of developing the disease is 10 times increased. Now, the monogenic forms of obesity, like, for example, a leptin deficiency or Prader-Willi, generally present in small children below the age of 5, and they will have other syndromic features. This is not something that presents in adolescence or adulthood, and this genetic testing should not be pursued for the vast majority of our patients. So, unfortunately, I have had multiple patients who have had DNA analyses requested by various healthcare providers. Now, I have yet to meet a person where their DNA analysis does not say that they should eat a more Mediterranean-based diet and exercise more. DNA analysis is currently not clinically helpful to individuals. It's an expensive set of tests, and really there is no evidence currently to suggest that it improves outcomes for weight management. So really try and avoid referring your patients for these things. Now, as an endocrinologist, every day I have to have a very frank conversation with patients to explain to them that for most people, their obesity does not stem from a thyroid issue, a cortisol issue, or insulin issues. At most, hypothyroidism causes about 3 to 5 kilograms of weight gain. Cushing's syndrome, which is the abnormal and pathological production of cortisol due to a tumor of the pituitary or adrenal glands, is extremely rare and occurs in about 1 in a million people. So this is not something that should be tested routinely at all. And insulin resistance, which is a clinical diagnosis, not a blood test diagnosis, is a result of excess visceral fat, not a cause of it. So you see these patients every day, as do I. There's a lot of misinformation about menopause and weight gain. And many of my patients in midlife will tell me, Jocelyn, I woke up and I was suddenly 15 kilograms heavier. Now, physiology does simply not support that trajectory. So weight gain is very common in midlife, but the change that happens due to menopause is due to a change in body fat distribution. So we know that the reduction in estrogen levels lead to a more visceral fat deposition and less on the hips and the thighs, which is typically the distribution in premenopausal women. We think that an increase in FSH may also play a role in the change in body fat distribution. And you can see when we look at the results from the SWAN study, which followed just over 500 women over 6 years, that the overall net weight gain in menopause was actually quite small. So it was about 2.9 kilograms in weight gain. However, there was about a 3.5 kilogram increase in fat mass. So the difference is due to the reduction in muscle mass that happens as we get older. And on average, there was almost a 6 centimeter increase in waist circumference due to the increase in visceral fat deposition. As you know, estrogen therapies does not prevent weight gain, neither does it cause weight gain, but it may attenuate the changes in body fat distribution to some degree. So these are just the results from the SWAN study in a sort of a bit of closer detail. And as you can see, starting about 5 years before the final menstrual period, we have an increase in fat mass that tapers off about 2 years after the final menstrual period, and a reduction in lean mass that also sort of stabilizes about 2 years after the final menstrual period. And the reduction in lean mass is typically related to aging and a reduction in energy expenditure, as well as a reduction in physical activity. It is not necessarily a hormonal problem that will be fixed by menopausal hormonal therapy. So the sad fact is that diets do not work for most people in the long term. Whether it is Atkins, keto, paleo, the Banting diet, the South Beach diet, the low-fat diet, the Mediterranean diet, it's really enough to make you scream. We have a lot of good evidence that no matter what the constituency of the diet is, most diets will result in some weight loss over 6 months, which will lead to an improvement in cardiovascular markers such as blood pressure, highly sensitive CRP, and A1C. But at 12 months, the effects on weight reduction and improvements in cardiovascular risk largely disappear. And this information is taken from a meta-analysis that was published in the BMJ a couple of years ago that looked at the outcomes of various 14 popular name dietary programs. So really, over a year's period, they are all the same. Effective at 6 months in terms of a little bit of weight loss and improvements in metabolic function, but at a year, most of those benefits have largely disappeared.
Jocelyn, I wonder if we just had a question. Can you comment on intermittent fasting, please? Are you going to?
Yeah, so intermittent fasting is fantastic for weight loss because you cut out 1 meal a day. That is really the only way that it works. It works on a calorie reduction basis. So to lose weight, you have to reduce your calorie intake. And intermittent fasting is a tool to do that because you generally cut out 1 or maybe 2 meals a day. It doesn't work in any other way. So it doesn't work in a magical way to help people lose weight. It works because people eat less.
So the bottom line is a calorie is a calorie is a calorie. That's what our colleague here says.
I think, there is some change in the field now, but I don't necessarily want to put this out there because it does, it's emerging evidence that the calorie from highly processed food is different from the calorie from, a legume and a whole food. So there is a little bit of emerging evidence to suggest that not all calories are necessarily created equal, but on a population-based level, what is needed for weight loss is calorie restriction, no matter where that comes from. And we have a lot of evidence to show that people do not change their dietary patterns long term. So if you've always eaten in a certain way and you go on a diet that excludes carbohydrates or reduces fat, and 2 to 5 years down the line, you will go back to how you were usually eating. So although it is important to reduce the amount of highly processed food and trans fat for overall metabolic health and well-being, I'm not overly precious about the content of the diet. But yes, there is emerging evidence to suggest not all calories are created equal.
Thank you.
I think it's important also to differentiate between weight loss and cardiovascular health. And to be cardiovascularly healthy, the best evidence is for the Mediterranean diet and the DASH diet for hypertension. And sadly, the Mediterranean diet is not pizza, pasta, and Aperol, as much as I would love it to be, but it is a diet founded in whole grain carbohydrates, a lot of vegetables, fruit, and lean protein with good fat.
What's a good fat, if you could just help us there?
Sure. So a good fat is anything that is sort of a polyunsaturated or monounsaturated fat. So these are things like avocado, nuts, and olive oil, as well as the fats found in fatty fish, such as salmon and mackerel and sardines.
Right.
So we've spoken a little bit about intermittent fasting. Those of you who are disciples of Jason Fung, I know will disagree with me, but really intermittent fasting works because you're reducing your calorie intake. There's a lot about the timing of meals and time-restricted eating. A lot of my patients will say, I don't eat anything after 6 o'clock in the evening. And I'm like, how do you have a social life? Really,
Yeah.
there is no evidence to suggest that timing your meals or eating in a specific time window is more beneficial for weight loss than overall calorie restriction. So at the end of the day, it is the number of calories that you're eating, not the space between meals and not the timing of meals. Now, sadly, we cannot target weight loss. And a lot of our patients in midlife will specifically mention the increase in abdominal fat, and they want to lose that weight specifically. Now, body composition is largely genetically determined. So up to 70% of body composition is due to genetics. So the fat is going to come on and go off where it is destined to. No matter whether you do 500 abdominal crunches a day, it is not going to give you a flat tummy. So we really have to target overall weight loss to help patients manage their weight. We cannot target where it is going to come off.
Because that's a common question. I find that women in menopausal status say that I want to lose this little fat pouch that I've got over here.
Yeah.
How do I do it? So the answer is
It's overall weight loss. So liposuction is not going to address visceral fat. So the problem is a lot of that is visceral fat. It's not necessarily subcutaneous fat. So liposuction is not a good tool for weight loss. It's a fantastic tool for body sculpting, but it is not a good tool for weight loss. And the abdominal fat is visceral, which is around the organs. So
Okay.
it's calorie restriction. However, we are going to guide our patients to do so. But what really is important is exercise may help with toning. So it might help, develop muscles in your arms and your legs, but it is not going to take the visceral fat away, unfortunately.
Right. Thank you.
Pleasure. So if you don't go home with anything else this evening, I want you to go home just with this slide. And I remember from psychiatry that the definition of insanity is doing the same thing twice and expecting a different outcome. This is what happens when patients go on repeated diets. Now, this is a meta-analysis of various studies that looked at different lifestyle interventions to achieve weight loss. So this was without medication or surgery. And you can see that in the dietary period, some of these patients lost a significant amount of weight. But what happens when you follow these patients up after several years? So if you look at 2 years, most patients would have regained more than half of the weight that they'd lost. And when you follow them up at 5 years, most patients would have regained more than 80% of the weight that they've lost. So unfortunately, for the vast majority of individuals to undertake a diet and exercise program, this is not going to result in long-term weight loss. So before we get into weight management, a common question that I often get is about exercise. And patients will tell me, Jocelyn, I've joined boot camp, I've joined the gym, I've started Pilates, and it hasn't shifted my weight. And I tell them that is entirely unsurprising because you cannot outrun your fork. Exercise is not a good tool for weight loss. It is a fantastic tool for cardiovascular health. It improves physical health, mental health, and well-being, and it improves metabolic parameters irrespective of weight loss, but it does not lead to significant changes on the scale. Okay, So,
Jocelyn, just on that very point. You're
yes.
an endocrinologist. Someone says here, if a person wishes to diminish their cholesterol and other fatty acids, is it best to do a diet or is it best to do a statin? Some people say, forget the diet, use a statin. What do you say?
So it depends what your overall cardiovascular risk is,
Yeah.
which will determine your LDL target. So there's not a one-fits-all solution to managing hypercholesterolemia. What we need to do when we're looking at a patient and their lipogram is to firstly risk stratify. So whatever tool you decide to use, I still use the Framingham risk score. We need to decide what is this individual's 10-year risk of having a heart attack or dying.
Yep.
That gives us a percentage, and that percentage informs what your LDL target should be, whether it should be less than 3, less than 2.5, or less than 1.8, or even less than 1.4. That will determine whether we can manage with lifestyle intervention alone or whether we need to start statin therapy. For a lot of people, it's a combination of the two. And for some people, because of their LDL level or their Framingham risk, they'd need a statin upfront. But it really depends on overall risk.
Thank you.
Pleasure. Okay.
Sorry, on that, so now I just asked
Yes.
you, there's all these questions. Which risk calculator do you use?
I use Framingham. It's easy. It's very easy to use.
Okay.
So I use Framingham.
Thank you very much.
Yeah. So easily available. It's a calculator online from MD Calc. And it's simple. It's easy. You need a lipogram and a blood pressure. And then you can calculate it for the patient. Pleasure. So enough doom and gloom from me. How do we actually help our patients manage their weight? So telling people to eat less and move more without giving them the tools to do so is entirely unhelpful. We need to have common goals for our patients, what I want and what they want. We need to treat complications, and most importantly, we need to improve quality of life. So if I had a rand for every time I've heard this, I would be sitting on my own island. Because every day patients will say to me, I have tried everything. I don't know why I can't lose weight. Weight loss itself is actually quite simple. It's really giving people the right tools to do so, which is the challenge. So I hope I've made it clear that diets do not work for most people long term. Maintenance of weight loss after a lifestyle intervention is incredibly challenging. And this is another example. You can see that in some studies, people, again, lost a lot of weight. And this is unusual. In most diets, people lose about 3 to 5% of their body weight. But in one of these, people lost, on average, about 30 kilograms. But what happened when you followed these people up 4 to 7 years later is that they had regained most of the weight. And in 2 studies, they'd actually regained a little bit more than they'd lost. And why does this happen? So this does not happen due to a lack of self-discipline, due to having no motivation, or due to being lazy. It happens because of biology. So what we say in obesity medicine is that obesity begets obesity. And what that means is that our bodies are not designed to lose energy. We are designed to conserve. This physiology served us very well in prehistoric times when we were running around woolly mammoths and we did not know where our next meal was coming from. But what happens in modern day when we try to lose weight is that, number one, our appetite starts to increase after a period of time. And number two, our energy expenditure, so how many kilocalories we're losing per day, goes down. So the net effect of those two things is weight regain. So this has got nothing to do with falling off the wagon. It's got to do with your body's programming to calorie restriction. So just to show you again, because this is really important. When we are dieting and we are restricting calories, we have a reduction in our satiety hormones like leptin, an increase in our hunger hormones, and this is in the region of 95 kilocalories per kilogram lost. So for every kilogram you lose, you're 95 kilocalories hungrier. Our energy expenditure declines in the region of about 25 kilocalories per day. Sorry, 25 kilocalories per kilogram lost. So the net effect of losing 1 kilogram is that you are 95 kilocalories hungrier and you lose 25 kilocalories less in terms of energy expenditure. So of course, your desire to eat goes up with hunger. You conserve energy and weight regain is almost inevitable. And so it really then makes sense that the only way to lose and to maintain weight loss is to help suppress that increase in appetite long term. Because we cannot expect people to maintain a lower calorie intake if they are hungrier. Remember, going back to the beginning of my talk, hunger is an involuntary emotion. Yes, you can decide whether to eat or not, but it is very difficult to resist an involuntary emotion long term. And
so, Jocelyn, it almost sounds like there's like a set point weight for every individual. This is what you bound to be.
The set point theory is controversial, these are all theories, Peter. We don't actually have as yet an exact reason why this happens. We have many theories about it, but we don't have an exact, there's no proven theory. But we do know probably that when you've reached a certain threshold in terms of excess fat, your physiology changes. And keeping that weight off just with diet is not effective because of your body's response in terms of appetite and energy expenditure. So we do think that when you've passed a certain threshold, this sets it in motion. So for most people, the problem is not metabolism, it is calorie intake. Okay. Now, a lot of my patients will tell me, Jocelyn, I really don't eat that much. I eat less than my husband. My friends always tell me how little I eat. I really don't understand. Now, this is a universal fact that people almost always underestimate their calorie intake and overestimate their physical activity. They are not trying to deceive you. People just don't remember that they had the biscuit with their morning coffee when they went to drop their kids off at school, or they finished their children's lunch when they got home, or they had that extra bag of sweets when they were sitting on the couch watching TV. People do not remember these things. They are not purposely trying to lie to you. There are just issues with the food memory bank in people who have obesity. And I've actually stopped asking people what they eat because I find that it's generally, it's not reliable and it's actually quite unhelpful in terms of guiding management. So getting to the crux of our talk today, and that's really the pharmacotherapy for the management of obesity. And we've come quite a long way since the Fat Girls Diet that was published probably over a century ago in a newspaper. So before we get into what really works, I want to tell you what does not work. And these are not weight loss drugs, either because they do not work for weight loss or because they are dangerous. So things like Ultroxin, if you do not have hypothyroidism, is dangerous to you. Do not use that if you do not have hypothyroidism. Glucophage and Jardiance are fantastic drugs for glycemic control in people with type 2 diabetes, but they are not good weight loss drugs because they do not lead to significant weight loss. The GLP-1s that do not work significantly for weight management beyond type 2 diabetes are Trulicity, which is dulaglutide, and Byetta. So these should not be prescribed for weight management because they don't work well. I was quite unpopular recently at the launch of Wegovy in Cape Town, where I said that there is very little evidence for the use of Insumax or sort of inositol in the management of polycystic ovarian syndrome, which I maintain, but there's also very little evidence, i.e. no evidence, that it is helpful for weight management. And then finally, testosterone in both men and women is not a weight loss drug. And if these over-the-counter preparations and snake oil sellers actually worked, we would all be skinny. So what does work for our patients? So the incretin group of medications has really been a game changer in the management of obesity. And we have the following people to thank for making these drugs universally famous. People like Elon Musk have openly admitted to using GLP-1 therapy to help them manage their weight, as did Oprah Winfrey, Robbie Williams, Mindy Kaling, Jessica Simpson, and most likely the Kardashians, although they have not admitted that publicly. Now, what are incretin drugs? So the incretin effect is something that was first described in the world of diabetes. So what that means is that when we eat a carbohydrate-based meal, we have a higher insulin response than when glucose is infused into a drip. So that's called the incretin effect. So a lot of insulin comes out of your pancreas when you eat something, as opposed to when you are given a dextrose infusion. Now, this is the incretin effect in healthy people. You can see this is after an oral glucose load, your insulin goes way up, as opposed to an attenuated effect if you are given a glucose infusion. In people with type 2 diabetes, this effect is significantly reduced. So the class of medication, which are the GLP-1s and the GLP-1s and GIPs, are incretin-like drugs. That's how they were initially developed. So these drugs help your pancreas to produce more insulin, and they reduce glucagon, which is an anti-insulin hormone. And that is why they're fantastic for the management of type 2 diabetes. For weight loss, however, these drugs work on those parts of your brain that manage hunger, whether it is hedonic or homeostatic. And they work to reduce hunger and improve satiety, which is the feeling of being full. They do not work in any other magical way currently to reduce weight. It is solely based on appetite suppression. So just a note here, there are GLP-1 receptors in almost every organ in the body, and that is why these drugs are such an exciting prospect for the development of to treat other diseases. There's a lot of work on these drugs in terms of the neurodegenerative diseases, dependence disorders, Alzheimer's, Parkinson's. They're really exciting in terms of offering us other treatment targets. So these drugs work to reduce quantity. In theory, you can lose weight by eating one Big Mac a day, because a Big Mac contains 580 calories, which is less than a peanut butter bomb from Kauai, I'll have you know. Really, with weight loss, we're speaking about a reduction in quantity, because remember, people do not change what they eat long term. They might change that for the purpose of a dietary intervention, but they'll often go back to the way that they usually ate. We need to differentiate weight loss from cardiometabolic health. And remember, that's your Mediterranean diet and your DASH diet. And that's the diet that's high in fruit and veg, lean protein, good fat, and whole grain products. But this way of eating is not necessarily low in calories. So you can follow a very healthy Mediterranean-based diet, salmon, olive oil, yogurt, all those delicious things, but that is not necessarily going to make you lose weight, because those are often high-calorie foods. Now, working in Cape Town, a lot of our patients, as do I, enjoy the fruits of the vine that the Western Cape has to offer. This is something that I do ask about quite specifically in terms of dietary history, and that is, what is your alcohol intake like a week? Because unfortunately, even though it is a wonderful pastime and rather delicious, alcohol is a very high calorie product. So you can see here a standard, which is the French standard, not the South African standard glass of wine, is 133 calories, which is equivalent to 3 Jaffa cake biscuits. A 5% strength beer is 1 standard size Mars bar. A double gin is also 1 standard size Milky Bar. So there are often hidden liquid calories in alcohol, and this is something that's a really important point to discuss with your patients. So moving on to the last part of my talk, and I know that we sort of press for time, so I'm going to go through these quite quickly. Who would benefit from these medications? What do we have available in South Africa? How much weight do people lose when using the drugs? Common myths and misconceptions around the medication, and what are the common side effects? So the current guidelines rely on BMI only when prescribing these drugs for patients. And as I've made quite clear in the beginning, BMI is not a good tool to assess obesity. So even though we use BMI as a criteria in clinical trials and in prescribing medication, this is currently flawed. But the trials were done in patients with a BMI of 27 or more with a comorbidity, such as hypertension or diabetes, or a BMI of 30 or more without necessarily having to have a comorbidity. But we know that we're probably missing a lot of patients with lower BMIs who may benefit from the drug. What we currently have available in South Africa is Saxenda, which is liraglutide. It's a daily injectable. And then our weekly injectables, which are newer generation GLP-1s and GLP-1s and GIP, which is semaglutide, which is currently marketed as Wegovy, but you'll all know it as Ozempic. But the Wegovy preparation is the one that's registered for weight loss. And then tirzepatide or Mounjaro, which is currently registered for the management of type 2 diabetes in South Africa, but the weight loss registration should hopefully come through shortly with SAHPRA. But of course, a lot of us are using this off-label at the moment. So remember, these drugs work on the part of your brain that controls appetite. They reduce hunger and they improve satiety. So patients do not feel hungry between meals and they feel fuller much earlier into a meal. GLP-1 is a naturally occurring hormone that is secreted by the L cells in your gut, as well as some cells in the hindbrain. So these drugs are GLP-1 receptor agonists, so they mimic what GLP-1 would usually do. So I'm really going to focus on the 2 heavy hitters, which are the best available treatments we have at the moment to manage obesity. And that's Wegovy, which is same as Ozempic, just comes in a different pen, and Mounjaro. So I always explain these drugs to my patients as being similar to the evolution of iPhones. So you can think of Saxenda, which is the daily injectable that we used to use as like the iPhone 8. Wegovy is like the iPhone 12, 13, and Mounjaro is like the iPhone 16. So these drugs continue to get better with modern technology. So Wegovy and Mounjaro belong to the same family. So they are GLP-1s, although Mounjaro is a GLP-1 combined with a GIP, which is another gut hormone. So it's like the younger, sexier cousin of Wegovy. They both work to reduce hunger and increase satiety. They are both given as weekly injectables, and they have a similar side effect profile, which is mostly gastrointestinal. I'm not going to go too much into the trials because I know that we're pressed for time, but the STEP trials was the clinical trial program that was developed to evaluate the effect of Wegovy, which is semaglutide, on weight loss. And there are multiple clinical trials in this program. And the one that I'm really just going to tell you about is step 1, which was the first one. And the step 1 trial assigned patients to Wegovy in the blue or placebo in the gray. I think there were just under 2,000 patients in this trial. Most of them were women, so about 70% were women, and most of them were in midlife, so in their mid-40s. They had a starting weight of about 105.3 kilograms, and the trial ran over 68 weeks. So as you can see, the group who received the active ingredient lost on average between 15 and 17% of their body weight at the end of the treatment phase, which was at 68 weeks. You can compare this to the 2.5% that the placebo group lost. So really groundbreaking in terms of the effect. It was the first drug where 50% of participants lost at least 15% of their body weight. And this has really become the new number when we're speaking about obesity management is 15 to 20%. So half of participants lost at least 15% of their body weight on this trial. Now, when patients ask me, when do I stop the drug? I tell them when you want the weight to come back. So you can see here very clearly from an extension of the step 1 trial that when they stopped the drug at 68 weeks, they continued to follow these patients up for another year. And this is at the end of that follow-up period, most people had regained most of the weight that they had lost. You can see that at the end of the active treatment program, the average loss was about 17%, compared to 5.5% of body weight loss at the end of the year after they stopped the drug. So the risk of weight regain is significant. Why? Remember what happens when you lose weight? Your appetite goes up and your energy expenditure goes down. So this is what would happen with any kind of diet. So this is the step 5 trial, which looked at continuation of the drug over 104 weeks, so over 2 years. And you can see that the weight loss was maintained over that treatment period. So the medication really leads to sustained weight loss with continued use. I particularly love step 3. So the step 3 trial looked at combining semaglutide or Wegovy with an intensive behavioral therapy, or which comprised a lot of dietitian visits and exercise. And what they found is that in patients who combined Wegovy with exercise, there was only a minimal difference in weight loss compared to those who just used Wegovy. So in patients who just used Wegovy, there was about a 15% loss of body weight on average. When you combine that with exercise and regular physical training, it only went up to 16%. So the drugs are so powerful that adding intensive behavioral therapy does not make a significant difference to weight loss.
Jocelyn, there's so many questions. I just want to get
yes, sure. Sure.
Duramine, do you have any comment, yes or no?
Duramine is fantastic if you want to lose 5 kilograms before your wedding.
Okay, that's
but
that.
it's not a long-term obesity management drug.
All right, so if I wanted to get married again, I'd use Duramine.
There we go.
Okay, then is it true that semaglutides also cause loss of muscle, which cannot be regained? Yes or no?
Any weight loss, whether it's from diet, exercise, medication like semaglutide or tirzepatide or bariatric surgery, may cause muscle loss.
Oh dear.
People will lose, on average, when they lose weight, 2/3 of that will be fat loss and about 1/3 will be muscle loss. No matter where it's from, it is not the drug that causes muscle loss. It is the significant loss of weight. it is more prevalent in our consciousness now as a society and as healthcare providers because people are losing a lot of weight very commonly because of these medications. But this is something we've been aware of in our patients who underwent bariatric surgery for decades. To avoid that, protein and weight-bearing exercise.
Okay, thank you. That's the bottom line. Comment on Ozempic being associated with acute loss of vision. Is it still safe to prescribe it? Yes or no?
Yeah, it's a good question, and it's come up often in the consultation now because of the big lawsuit against Novo Nordisk. So what we saw in the STEP trials, which was the big clinical trial program I've just told you about, is that we did not see any change in visual acuity during the clinical trials or post-trial surveillance. There has been, in patients with type 2 diabetes, a slight increase in diabetic retinopathy in patients who have type 2 diabetes when using semaglutide for diabetes management. It does not worsen existing retinopathy in patients with type 2 diabetes. So there are a handful of case reports about ischemic optic neuropathy, which is present with acute visual loss in patients who do not have type 2 diabetes and are using semaglutide for weight loss, but we don't have a good mechanistic reason as to why that might happen. And it's currently something that is under surveillance. So for me, prescribing this drug, it is not yet a founded fear, but it is something that I do think we need to watch sort of in post-marketing surveillance.
Thank you very much. Moria Stein, loved your presentation, as do we all. And then Innocent says, any studies on long-term possible negative side effects of these medications? Any?
So I suppose the question is, how long is long-term? Now, the drugs, GLP-1s have been in clinical practice for more than 20 years. So far, we do not have any evidence to suggest that these are detrimental. We have lots of evidence to suggest they are very beneficial for patients. In terms of cardiovascular safety and protection, the SELECT trial published last year showed that people using Wegovy had a 20% lower risk of dying from heart disease, stroke, and when using Wegovy compared to those who did not. So if anything, the medication is probably going to make you live longer. We have no good evidence to suggest that there's a significant association with thyroid cancer. And where that scare comes from is that in rodents who have a different thyroid to we do, as to we do, there is an increased risk of medullary thyroid carcinoma in rats given GLP-1s. That has not manifested in human beings as yet, but we don't recommend using the drug in patients with a personal or family history of medullary thyroid cancer, which is a very rare kind of thyroid cancer. So I know that question comes up quite often, so I just wanted to preempt it.
Okay, thank you very much, Jocelyn.
Any more questions? Now, can I carry on with the last few slides?
Carry on with the last slides, yeah.
So the new kid on the block is tirzepatide, which is Mounjaro. Remember, not yet registered for weight loss in South Africa. We're using it off-label. But this is a twincretin, which is a combination of a GLP-1 and a GIP. And on average, with the highest dose, we see a 20.9% loss of weight at 72 weeks. With the 5 milligram dose over here, we see a 15% loss of body weight. With a 10 milligram dose, we see a 19.5% loss of body weight. And then finally, we see the 20.9% loss of body weight on average with a 15 milligram dose over a 72-week period. So an incredible drug that's really approaching bariatric surgery numbers.
Wow.
I'm not going to go into these in any detail because I know that we are pressed for time, but this is just the SELECT trial that I mentioned earlier, which looked at the cardiovascular safety and benefit of Wegovy 2.4 milligrams in terms of reducing death from cardiovascular disease over a 4-year treatment period. So just to summarize what these drugs do. So Saxenda, which is liraglutide, we now consider quite an outdated drug, which is the daily subcutaneous injection, results on average between 8 to 12% of body weight loss. Semaglutide, which you all know is Ozempic, but which is now available in a Wegovy pen, which is just a bigger pen, is a weekly injection. And on average, the 2.4 milligram dose results in a 15% loss of body weight, as you saw in the STEP trials I mentioned earlier. And then tirzepatide, which is Mounjaro or Zepbound, the weight loss preparation, the 15 milligram dose, which is the highest dose, results in about a 21% loss of body weight over 72 weeks. So really effective and potent therapies. Side effects, mostly gastrointestinal. Nausea is common, constipation is common, and some patients may have diarrhea or dyspepsia. It's important to start these medications on a low dose and you go up slowly. So you increase the dose, the weekly dose on a monthly basis, and the patient should not increase their dose if they're still having side effects on the drug. They wait until the side effects have passed before increasing the dose. Advise on smaller meals that are lower in fat, because a high fat meal makes people feel a lot worse. They need to maintain a fluid intake of at least 2 liters a day, and to prevent constipation, fiber of between 25 to 28 grams a day, which is a lot of fiber. These are just some common myths and misconceptions which we've already addressed, but probably the most important one here is using the drug to kickstart weight loss and then stop. So there is no quick kickstart or quick start to weight loss. Weight management is a chronic management program. And as you can see from the STEP 1 trial, when the medication is stopped, the risk of weight regain is significant. Now, we were chatting about this briefly before we started the talk. And this is important for you as gynecologists. So there are a lot of issues now and a lot of discussion about GLP-1 use in women of reproductive age, because the amount of women of reproductive age who are using these drugs has increased exponentially in the past few years. It's important to know that with contraception efficacy, tirzepatide reduces the efficacy of the oral contraceptive. And it does this by delaying gastric emptying, which impairs absorption. So with tirzepatide, which is Mounjaro, patients should use alternative forms of contraception, such as condoms, or have an IUCD placed. These drugs are not approved for use in pregnancy and breastfeeding, and we advise that patients stop them 1 to 2 months before trying to conceive, which is challenging, I agree. But with Wegovy, they should stop the drug at least a month before trying to conceive. With Mounjaro 2 months before. Having said that, the drugs appear to be safe in pregnancy for those women who have unknowingly continued them during a pregnancy, and we don't have any reports of significant teratogenicity thus far. So food noise is a concept that is very current in sort of social media and pop culture. And this has really been brought to light with the use of GLP-1 therapy. And what food noise is, and it's a concept I'm sure your patients may have mentioned to you, is sort of a constant background chatter and thinking about food. So it's not hunger per se, but it is thinking about food choices. And this can be something that is actually very distressing to the patient, because you might wake up and think, I'm quite hungry, but I don't know what to eat because I want to lose weight, but I'm hungry and that looks really nice. So it's a constant background noise around food, which can be very distressing to that individual. And these drugs really help to decrease that even further. So just a quick note on bariatric surgery before we finish off, and I'm happy to take some questions after that, is that do not forget about bariatric surgery, which is still the most effective tool to treat obesity. And you can see with the gastric bypass procedure here, the green line at the bottom, the average weight loss at a year after treatment is about between 30 and 35% of body weight. There's often a little bit of weight regain that happens over 20 years, which is considered to be normal, but now we often use GLP-1 therapy post-surgery to prevent this from happening, but it is an incredibly effective treatment for obesity. We've touched a little bit about how we manage the concern about muscle loss on these drugs, protein, and weight training, and then again, how to manage potential side effects with fluids and fiber. So I think I'm going to stop there because I'm sure there are some other questions that people have, and I don't want to sort of take up any more of your Thursday evening. So Peter, if there's anything from the audience, I'm very happy to address those questions.
And Jocelyn, it's been a wonderful talk, as everybody has said. I've had lots of people saying it's a very worthy subject, and you've done beautifully in it. We've come a long way. I remember people that used Orly Whip and had leakage of fats and stool through their rectums. What's that called? Orly Whip? Sounds
Orly
like
that. I mean, basically Orly Whip, similar.
Yeah, Orly Whip. And we are now using Manjaro, which is wonderful. And you've given us beautiful insights. Jocelyn, we've run out of bandwidth, but I'd like to, on behalf of the Pelvic Floor Foundation, thank you greatly and immensely for your wonderful presentation. And I hope one day we'll be able to come back and carry on the conversation. With all our very best love, and thanks to Chris also. And see you all next week. Good night and God bless.
Thank you. Cheers.
Thank you, Jocelyn. Bye-bye.
Bye.